A couple questions, and the first one is, I know that you are absolutely passionate and committed to working with men and working with gender-responsive care and with trauma-informed work. And this is really a question to help all the counselors out there who are kind of recognizing the need for this. But what do you see as the really primary differences from a truly clinical perspective of working with men as they come into the system as opposed to working with women who are entering the system?
That's a great question, and we could probably write a 3-volume text on it. The approach that Dan Griffin and I have taken, my co-author along with Stephanie Covington in Helping Men Recover and my partner in doing trainings, is that the socialization process has a profound impact on the way that men and women experience traumatic events, how they respond to traumatic events, and how they heal from traumatic events. And that being trauma-informed without taking into account the socialization process and what men and women bring to bear with them as they enter into therapy is absolutely essential. Our focus is on men, and one of the things that we know is that men are strongly conditioned to deny pain, to not acknowledge weakness, to not talk about fear, to appear strong and powerful at any cost. And we know that traumatic events, for the most part, render people feeling powerless, feeling hurt, feeling scared, feeling vulnerable. And so men don't have the coping mechanisms to deal effectively with the traumatic event and go in one of two ways. They either shut down and become avoidant and isolative, or they act out in aggressive and sometimes violent ways. And this is really all about protecting themselves and finding a place of safety so that they don't get hurt again. And articulating that and normalizing that for the men is an extraordinarily important piece of the therapeutic process. There's a word that we use that isn't really a word, but I like it, and it's depathologizing behavior. In other words, the things that you've been doing were a natural, normal, rational response to the events that have occurred in your life, and we want to honor the fact that you survived that, and you did good. But now that that threat is no longer as present or as dangerous, you might want to look at some different coping strategies. But that's up to you. And that's the important part, is giving men room, giving them a space to explore this, giving them permission, and honoring the effort.
Okay, great.
Yep.
So I know you and Dan travel all over the country. You do training, you go into an agency and you really teach them the model from helping men recover. And so you probably see agencies that are slightly ahead of others in terms of that work, and some that are really at the beginning. And I'm wondering if you can talk a little bit about what you're seeing, and then maybe some of those agencies that are actually intuitively doing some things that maybe place them a little closer. So like where they're coming, some of those strengths you're seeing?
Yeah, that's a great point. We see the full gamut. There are agencies, as you said, who on an intuitive level, or because one of the decision makers within that agency has been exposed to some of these ideas, are practicing trauma-informed care without having the theoretical framework that they could easily articulate. They're doing it because it feels like the right thing to do. And I remember when I first started working in the field, one of the people that I read was John Bradshaw. Okay. John Bradshaw talked about the inner child, about the wounded boy inside of us. He didn't name it as trauma, but that was an important part of kind of my education and my sensibility about how to work with men. Learning more about the physiological response and learning about the process of trauma, and hearing all of these brilliant researchers talk about what they're discovering is extremely affirming for me, because I come from that intuitive place.
Sure.
I know deep in my bones that confronting a man and breaking him down is not the way to help him heal. That the way to help him heal is by giving him a place where he feels as though he has a voice and he can take some risks without being judged and without being ostracized. I've just have tried to practice that without, until fairly recently, being able to give a name to it.
It's interesting, as you were talking, I was thinking, so for those agencies where they're really struggling, I assume there's a pretty significant parallel process, that what's happening between you and that working and that staff is probably what's also happening between them and their patients.
Absolutely.
And so what, if you could, what mindset do you walk into those meetings with, or what are some of the really primary things that you're trying to capitalize on in that process?
Well, one of the first things that we do when we begin talking to an organization, whether it's a drug court jurisdiction or a treatment center or a community mental health facility, is the idea that we want everybody who works at that organization to be part of the training. That means the program assistants, it means the housekeeping people, the maintenance people, the techs, the drivers. We really believe in a top-to-bottom process, as Roger has referred to.
That's what I was thinking when you were
talking. And I mean, it's such a fundamental aspect of our notions of trauma-informed care. We find a couple of things. We find that sometimes administrators want to remove themselves from the process, and it's sort of like, well, I don't have to worry about that. I'll let my clinical director do that. Sometimes chief executive officers will say, well, I want to use the material, but I'm not quite sure that I'm willing to kind of toss my entire organization into upheaval. And so they'll adopt pieces of trauma-informed care by using a particular curriculum or starting a particular group. And in some ways, that might even be more harmful than helpful. I started my profession working as a tech in a residential program on graveyards and weekends, and I, 30 years later, continue to believe that what happens outside of the group rooms is probably the most important stuff that happens in treatment. It's those interactions that occur when the guys are out having a break, or they're walking around the property, or they're driving in the van. The other thing that we've noticed is we work very hard to convince organizations that if we come out and do a training, they should invite us to come back 3 months later, or 4 months later, or 5 months later. It's easy to fall asleep. It's easy for the staff to get really excited and think, God, this is going to be great, and we're going to do this. And then come Monday, reality hits, and you've got 18 phone messages and 50 emails and discharge summaries, and agencies can get lulled back into a sense of complacency. So following up, there's an entropy that happens. Systems without some kind of external stimulation tend to deteriorate. So having us come back and sit in on groups and hear how things are going and doing a little bit of tune-up is a really big part of the work that we do. It keeps it alive for people.
Yeah, second order change is hard.
It is very hard.
So thank you very much. I appreciate it.
Thank you, Michael.